Welcome everybody to CHI's quarterly board education webcast, Compliance in Rural Healthcare and Critical Access Hospitals. We're pleased to provide the next in our series of compliance education webcasts that we provide for board members. I'm Michelle Cooper, and I am CHI's Corporate Responsibility Officer at the national level. And we're excited to offer this webcast today. We're using a new format, so we're hopeful everybody did not have problems joining, and we would appreciate receiving feedback if anybody had any problems with this new tool. Before we get started, I would like to offer the following reflection. This reflection was actually prepared by my assistant, Amy Knopp. She's very creative, and I really felt it was a wonderful reflection to share with the group today. It's called Let Us Use Our Eyes. Let us use our eyes to see where we may have been and set foot on a brand new path, a new day to begin. Let us use our eyes to seek the righteous way, to hold on to our mission and embrace it every day. Let us use our eyes, our minds, to forge a future brighter than any thus far told. Let us divine to seek the highest level, bearing fruit upon the vine. And we shall make the effort to join our purpose true, to move us forward the future in everything we do. And to God be the glory for all that we may do and all that we may accomplish. Let this be always true. And with that, just a few quick instructions. We are going to accept questions throughout the webcast, and I'm going to turn that over to Karen real quickly to define how you would go about posing a question, because you can pose the questions throughout the webcast, and then we'll take time at the end of the call to answer any questions that you post. So Karen, do you mind defining for the group how to do that?
Of course. You'll notice that there is a control panel in use now, and you'll scroll down. It goes Dashboard, Attendees, Polls, Questions. Looks for your questions, and then there is a box that you expand that. You are going to type your question, and it will go directly to Michelle, who at the end of the presentation, when it is announced it's time for Q&A, she will then present the questions to our panelists. At any time, you can submit your email question. I do want to let you know all attendees are on mute. We wanted to get best audio for this recording, so thank you for joining today.
Okay, great. And if anybody is in listen-only mode and is not accessing through the web, you may also submit a question by emailing Amy Knopp at catholichealth.net, and it's AMYKNOPP at catholichealth.net. And if you'll just type question in the up in the top, we'll make sure we address those as well. With that, I'd like to introduce two individuals. Sherry Heinisch, who is the Regional Corporate Responsibility Officer for the Fargo Division, and also she's actually our lead critical access hospital expert. And then also Randy McDaniel, who is one of our compliance officers or corporate responsibility officers in the Nebraska region. He's also one of our critical access subject matter experts. And I welcome both of them today. I'm going to turn it over to Sherry to begin the presentation.
Thank you, Michelle, and thank you, everyone, for attending our webcast today. So, as Michelle mentioned, I am with the Fargo Division. We have the largest composition of critical access hospitals in CHI. Right now, we have 13 critical access hospitals throughout North Dakota and Minnesota. Randy is based out of Nebraska. He has oversight of 6 critical access hospitals there. But, you know, every CHI market has at least one critical access hospital. And I think in total right now we have about 30 critical access hospitals in CHI's portfolio. So we wanted to talk today a little bit about the different risks that critical access hospitals have compared to their PPS or acute care counterparts. There's also a lot of disparity between the types of services that you're going to find from one critical access hospital to the next. So For example, we've got hospitals that have specialty services like orthopedics, obstetrics. We have an interventional radiologist at one of ours. We even have a plastic surgeon at our Williston Critical Access Hospital. So that presents challenges in itself because we really have to consider the types of services, and the regulations that control them when we look across the spectrum for a compliance program. So I wanted to talk today a little bit about some of the things that that we've been dealing with over the past couple of years. We've got the impact of the 96-hour physician certification rule. There's been a lot of behavioral health issues that have been rising in rural communities, and then the 340B drug pricing program and the challenges and the benefits we see from participating in that program. And then finally, we'll go through some takeaways for you as board members. But the bottom line, from a compliance perspective, our goal is really to ensure that our critical access hospitals, that we're compliant from documentation to coding to billing. Even though we are paid differently than an acute care hospital, we still need to make sure that those things are done in a compliant fashion. And, ultimately, we really want to demonstrate that patient care is not compromised at these rural hospitals because we really need to make sure that we can continue to serve the mission of the sisters. So we will go on to our first topic today, which is the 96-hour physician certification rule. If any of you are in the Fargo market, you've probably heard about this more than a couple of occasions. But these are the two rules that we're dealing with here. So one of them is a condition of payment. The other is a condition of participation. Historically, our critical access hospitals have been following the condition of participation in that we were measuring that we were not exceeding on an annual average basis 96 hours. So that's what has always been measured. We met that requirement. It was basically that's the industry standard. Until about September of 2013, CMS issued some guidance around the 2 midnight rule, and embedded within that guidance, they made reference to this condition of payment. So we all kind of read that and thought, what are they talking about here? It generated a lot of questions to CMS. This condition of payment, as you can see, that was a 1997 law, and then the condition of participation came along in 1999. I think the assumption was that the condition of payment was superseded by the average length of stay participation requirement. So we had a lot of questions for CMS, not just within CHI, but across the country, and that resulted in CMS coming out with some new guidance in January of 2014, and they really came back and said, that condition of payment rule is out there, so that's what we expect you to do. We expect you to have the physician sign a certification that a patient will be discharged or transferred within 96 hours. They did have some exceptions allowed, and we review those on a constant basis if we have patients that go over. But the problem was this isn't what anyone in the country was doing. So when we started having really serious discussions about this, because CMS was very clear here, I think a lot of the leadership teams at critical access hospitals were very concerned that with this type of language that the providers would, be hesitant to even admit patients to the critical access hospitals, and so, this could ultimately put us out of business. So what we decided to do at CHI here was that we would obtain a legal opinion. We wanted to find out if, what kind of a risk did we assume if we did not follow this 1997 guidance and instead followed the average length of stay, which is, like I said, had been the industry standard. So we went to Polzanelli law firm for their opinion on that, and Polzanelli came back with some information that we were a little disappointed to see, but indeed they said, yes, if we proceed to practice on an average length of stay, we are potentially submitting false claims, because we wouldn't have a certification. There could be stays that go longer than 96 hours. But not only that, they said if you're not doing this going forward, we're also risking a potential for a retroactive review by CMS. So meaning that we'd have to go back, 4 to 6 years and potentially make repayments for any stays that didn't have the certification. So we got busy. We put a lot of education together. I think I missed a slide there, and I apologize about that. We did a lot of education with 2 new providers. We went out to the boards, educated them. We had our CNOs working with other areas of the hospital to put a process together. And so we went live with it in August of 2014. So, overall, I think what we've found in the past 2 years, it wasn't as significant an impact that we originally thought it was going to be. The providers did not seem to have a concern about certifying that their patients would be discharged or transferred within the 96 hours. We've seen very good documentation supporting any lengths of stay that went over the 96 hours. We've had some different scenarios that have been raised up, and we've run those through legal as well to get opinions on other circumstances that would have necessitated a longer stay. But I think found interesting is we had a surgeon at one of the hospitals. He actually changed the way he performed a procedure, so he ended up reducing the inpatient stay. And from what I've heard, I think the patients have generally been happier with their outcomes. They're feeling better. They're getting out of the hospital sooner. So that was a positive as well. So what I would finish up with on this from a governing board perspective, as far as what you could do to help with ensuring compliance, is that make sure, follow up with management, and ask if education is being provided to the new physicians that are coming on board. Query them about enforcement. So, questions like, is management, are they periodically reviewing the inpatient stays, to make sure that certifications are complete? If there's outliers by the physicians, for instance, if they're not completing a form or completing necessary documentation to support an extended stay, is management, circling back with that provider and providing more education? And I think, asking management on transfer patterns, if they noticed an uptick in transfers. I have not really heard any concerns around that, but they could be out there. And that might be something that management should take a look at and see if there were any unnecessary transfers being made. So that is sort of the end of my presentation on the 96-hour certification. With that, I'm going to turn this over to Randy McDaniel to talk about telemedicine and behavioral health.
Thank you, Sherry. Today I want to provide some information on telemedicine, specifically with some of the nuances as it relates to behavioral health. And as I'm sure most of you are aware, rural healthcare facilities currently lack adequate healthcare professionals to provide care as their state's healthcare providers shortage worsens. Telemedicine allows patients in rural communities to meet with specialists without traveling to clinician offices, and may be a method to ease the workload for doctors at smaller community hospitals. This lack of professional healthcare resources in rural communities also includes behavioral health professionals, as well as the challenges that have always, or seem to have been in place for a long time, regarding access to psychiatric hospital beds. Telepsychiatry is a new frontier, if you will, in behavioral health that's providing alternatives to rural health providers. Telepsychiatry has both diagnostic and therapeutic applications, including pre-hospitalization assessments and post-hospital follow-up care, medication or pharmacological management, and consultation. And the video conferencing that's part of telemedicine allows multiple providers to collaborate on a case regardless of their proximity to the patient. Along with all this new technology for delivering healthcare services via telemedicine, there are risks that need to be vetted and addressed. And some of those risks include credentialing and privileging the telemedicine providers, quality of care, protecting patient privacy, security of the patient medical record, and some of the additional requirements for informed consent for a behavioral health telemedicine encounter. Next slide, please. So to begin with, I want to review some of the current CMS regulatory requirements for telemedicine services. So in May of 2011, CMS published a final rule that was effective in July of that year, which governs agreements under which a hospital or critical access hospital may provide telemedicine services to its patients. Under this new and revised regulation, telemedicine services can be provided under a written agreement between the hospital or critical access hospital and one or more what are referred to as distant site hospitals that participate in Medicare, or as an entity. And for purpose of this rule, a distant site telemedicine entity is defined as one, it provides telemedicine services, two, is not a Medicare participating hospital, and three, it provides contracted services in a manner that enables the hospital using its services to meet all the applicable CMS conditions of participation. One of the aspects of the written agreements needs to address credentialing. So a written credentialing agreement has to contain the following provisions requiring either the distant site hospital or the telemedicine entity to meet. And one is to be sure that they're using a credentialing and privileging process that at least meets the Medicare standards that hospitals have always been required to use. And secondly, they must ensure that the distant site hospital or telemedicine entity has granted privileges to the individual practitioners and physicians providing telemedicine services. They must ensure that the distant site telemedicine physicians and practitioners hold a license that's issued or recognized by the state where the contracting hospital is located. And they must also provide a list of telemedicine physicians and practitioners to the contracting hospital who are privileged and what those current privileges are at the distant site hospital or the entity. The hospital or critical access hospital must, under the terms of a credentialing agreement, review the services that are being provided by its practitioners, and then provide feedback to the distant site hospital or telemedicine entity, at a minimum, addressing all the adverse events, or complaints that are related to telemedicine services. And as I'm sure you're familiar with, per the CMS Critical Access Hospital conditions of participation, all critical access hospitals must, as part of their quality assurance program, have an arrangement with an outside entity to review the appropriateness of the diagnosis and treatment that's being provided to its patients. This includes physicians and practitioners that are providing telemedicine services. So under the new provisions of the telemedicine services, in the case of the physicians who provide the services to critical access hospital patients under a written agreement with a distant site hospital, it's the distant site hospital that's responsible for reviewing quality of care. In the case of providers, telemedicine service providers under a written agreement with a telemedicine entity, the outside entity responsible for reviewing that quality of care provided by those physicians can be a hospital that's a member of the same rural health network as the critical access hospital, or it can be the Medicare Quality Improvement Organization, or QIO, or its equivalent, or it can be another appropriate and qualified entity that's identified in the state's rural health plan that can perform that function. Next slide, please. Couple need to be reviewed by management, and one of the steps that needs to be taken to undertake is to review the medical staff bylaws to make sure that all the provisions for telehealth service providers are addressed in the bylaws. And one of those is to adopt this streamlined credentialing and privileging process for telemedicine physicians and practitioners that I've just spoken of. And the governing body of the critical access hospital has an option. They can either rely on this streamlined process for these telemedicine physicians and practitioners, and if they do, the governing body should ensure that the written credentialing agreement requires all 7 of the requirements in the COPs for medical staff credentialing. But one note I want to raise here, the governing board must ensure that the state hospital licensing regulations where the contracting hospital or critical access hospital is located are compatible with this streamlined process that CMS has allowed. Amending the hospital's medical staff bylaws to adopt these streamlined process may not permit the contracting hospital to meet the state licensing requirement. And that's currently one of the challenges that we're having in the state of Nebraska. And finally, if the critical access hospital governing body does not want to rely on this streamlined process, either at the distant site hospital or distant site entity, then it has to go through its normal standard process for review of credentials and granting privileges to physicians and practitioners. A couple other elements in the bylaws that you need to make sure there are provisions for: establish a medical staff membership category for medical or telemedicine physicians and practitioners, and then establish telemedicine privileges. And I also want to note, I've made a note here on the slide, CMS has implemented survey procedures that are specific to telemedicine services that are in conjunction with these regulations that were rolled out in 2011. And most of the survey elements involve review of the required elements of the services and credentialing agreements. So I won't get into a lot of the detail on that, but it's something you need to be aware of. Next slide, please. So some of the verbiage definitions within telemedicine, you have a distant site, which is the location of the telemedicine physician and practitioner. And there are a lot of different types of providers that can be providers of telemedicine services, but they're all subject to state scope of practice law, of course. Physicians and advanced practice clinicians, clinical psychologists, and clinical social workers are just some of those. An originating site, per definition, is the location of an eligible telehealth individual, aka the patient. And the reason they have eligible here, the patient has to have Medicare Part B coverage because most of the telehealth services are reimbursed under the Medicare Part B program. And there are several different types of sites, locations that are considered an originating site authorized under these regs. Of course, the hospital of a physician or practitioner, a hospital or critical access hospital, rural health clinics, federally qualified health clinics, skilled nursing facilities, and community mental health centers. Next slide, please. So currently, Medicare beneficiaries are eligible for telehealth services only if they're presented from an originating site that's located either in a rural health professional shortage area or HPSA area, or they're in a county outside of a metropolitan statistical area. But caveat to that is Medicare is making some provision for telehealth and new payment models that don't require the eligible individual to be located in a HPSA area. So I think that's Medicare starting to move away from that requirement. The other thing, Medicare approval of new telehealth services and provision for reimbursement of telehealth are included each year as part of the Medicare physician fee schedule regulations. And CMS recently issued the proposed calendar year 2017 physician fee schedule regulations on July 7th. And there was a portion of that, if any of you had an opportunity to look at that addressed telemedicine and some of the things that CMS is using to determine if a service is appropriate for telemedicine or not. And just a side note, I became aware today at their annual meeting on June 13th, the American Medical Association has actually adopted ethical guidelines for the use of telemedicine based on that information. Next slide, please. Just briefly, Medicare telehealth services can include consultations, office visits, office psychiatry visits, and any additional services that are specified by the Secretary when they're furnished via a telecommunication system. And if you take an opportunity or have an opportunity to review the physician fee schedule regulations, the CMS kind of outlines what their process is for that. And there again, the originating site is paid a fee under Medicare Part B, and then the physician or practitioner at the distant site, his or her professional fee is also reimbursed under Medicare Part B, and it requires the use of a modifier to indicate that it was a service that was provided via telemedicine. So some of the other compliance matters outside of the scope of the CMS COPs that need to be addressed for HIPAA privacy, a business associate agreement would be required between the contracting hospital and the distant site hospital or telemedicine entity to enable sharing patient adverse events for peer review. And then also the contracting hospital would need to review their current notice of privacy practices to ensure that there's adequate notice to patients regarding the telemedicine services provisions. And then the contracting hospital should also take precautions to ensure that the behavioral health services, telehealth services, are provided in a location with the originating site and also the distant site that provides additional confidentiality and privacy to the behavioral health patient due to the sensitivity of some of those encounters. For security, you need to ensure that the interactive audio and video telecommunication system equipment and data transmission lines have necessary security to prevent unauthorized access to the audio or video communication of the telehealth service. And you need to ensure that there's a process in place to ensure that the visual and audio material, that if it's recorded and made part of the patient's medical record, that they're maintained in a compliant and secure manner. And you must also have a process to ensure that the behavioral health telehealth service records kept confidential, and a process is in place for restricting unauthorized access. And so I want to take a little bit of time to talk about that with electronic health record. There's various types of EHR applications, electronic health records, if you will. Some allow for restriction to certain parts of a patient record based on a job role, but there are others that aren't able to do that and require restriction by segregating the behavioral health record from the patient's designated medical record. And I want to tell a story or provide them as it relates to, I think, Fargo's experience with Meditech, and also what we have at our facilities here in Nebraska. When Fargo first implemented a new version of Meditech, they discovered that there was no way to specific provisions of the record, and in an effort to isolate the behavioral health record, had to take alternative means for a period of time before Meditech was able to provide the restrictions that were required for those parts of the record. And also the Allscripts application that currently in use in the Fargo division and in some of the Nebraska division hospitals, or excuse me, clinics, has no ability to restrict access based on job roles. So the clinics that are needing to provide some additional security to behavioral health type records have to use a segregation of that record from the regular designated record of the patient. So currently in Nebraska, they're on a different version of Meditech than what the Fargo division, as well as the Allscripts, which is in place in Fargo and Nebraska, requires the behavioral health record to be on paper, and that's the only way that they can restrict access to that portion of the record, whereas the Meditech 6 version in Fargo and then the EPIC applications in some of the Nebraska facilities are able to utilize a job role restriction, and they also feature a break the glass function that also helps restrict access to those behavioral health records. And something additional that I'm referenced to here on the slide regarding Section 504 for the Rehabilitation Act and Title 6 of the Civil Rights Act, practitioners furnishing telehealth services are reminded that these services are subject to the same non-discrimination laws as other services, including effective communication requirements for persons with disabilities and language access for persons with limited English proficiency. So both the originating site, which is the location of the patient, and the distant site, which is the location of the telemedicine provider, have to make provision for a patient's disability, either speech, hearing, vision, and must provide services of an interpreter if the patient has limited English proficiency. Next slide, please. So some of the state law requirements are written statements and informed consent requirements, if you will, for patients. And the contracting hospital must have a policy and protocol addressing when informed consent is required for obtaining video and audio images captured during the telehealth services. And also, as I said, these are usually state regulations and aren't part of the CMS COPs. So for example, in the state of Nebraska, the additional requirements for informed consent for telemedicine type health practitioner has to provide a patient with written information that has to be acknowledged. And some of the additional provisions of the informed consent is that there are alternate options that are available, including in-person services versus the telemedicine services. And whether the telehealth consultation will or will not be recorded is something that also has to be included in that consent. And then finally, the patient has to be informed of all the parties who will be present at each telehealth consultation and has the right to exclude anyone from either the originating or the distant site. And of course, a safety plan has to be developed should it be needed at any time during or after the provision of the telehealth services to accommodate any unforeseen circumstance. So to wrap up, next slide, please. Oops. Okay. I have some just a wrap up with some of the governing board responsibilities, and I'll go ahead and talk about them here. The slide may be at the end of the presentation, but you should query your management about 3 or 4 things. One, ensure that their written agreements have been executed with your telemedicine providers. Ensure that credentialing agreement includes all the provisions that are required by CMS, and ensure that the state law requirements are addressed, you know, as it relates to credentialing and peer review and informed consent. And then ensure that all the HIPAA privacy and security requirements, including restricting access to the behavioral health patient record, have been addressed. And that wraps up my presentation. I'll turn it back over to Sherry.
Thank you, Randy. Okay, we are going to conclude our presentation with discussion around the 340B drug pricing program. So 340B was established in 1992. This was where the pharmaceutical manufacturers agreed to provide discounts on certain drugs that would be used in the outpatient setting to certain covered entities. And the reason for that was, you know, the purpose of it was to help the covered entities keep providing services, you know, to low-income and uninsured patients through these discounts that they would receive on these drugs. So the the discounts typically range anywhere from 15 to 60% for drug costs, so it gets pretty significant. So when they started this in 1992, there were just a few what they call safety net providers. Again, these are the ones that are providing services to vulnerable patients. When the Affordable Care Act passed in 2010, the Act added 4 additional entity types as a safety net provider: the critical access hospitals, the full community hospitals, the rural referral centers, and then freestanding cancer hospitals. So for the purpose of this presentation, I'm really just going to focus on the requirements for critical access hospitals. I'm going to try not to get too deep into the weeds with some of these areas, but I wanted to hopefully give you a good understanding of what the program benefits are, what the risks are, focus areas. So we'll start benefits here. The savings that are realized from the program itself is really supposed to be used to provide or expand health care to rural communities or low-income individuals. We should be using it to improve patient safety and then being, you know, in a position to provide more comprehensive services. We really need to ensure that our hospitals are using the savings that we realize in alignment with the intent of the program. We don't have to document it, at least not yet. They haven't required that, but you know, it could be down the line that we will be asked to show how we're using those savings. But the benefits really are substantial. In the Fargo division over FY16, they had savings of roughly $4 million. So that really allows us to continue to provide services to some of the areas in North Dakota and Minnesota. But you know what the bottom line is, along with these substantial benefits comes substantial risks. So these are the areas of risk under a 340B program. We're looking at eligibility, diversion, duplicate discounts, and then the contract pharmacy piece of it. So we'll talk a little bit more about those areas. I just wanted to share with you a little bit about who the various stakeholders are in the 340B program. So we have the Health Resources and Services Administration, or HRSA, as I'll refer to them throughout this presentation. They're the ones responsible for administering the program. And the program is huge. They expect in 2016 that annual drug spending in this by $3 340B providers will exceed $12 billion. So it is a very large program. Part of the reason they think that it's going to get that high too is because the Medicaid coverage expansion. So underneath HRSA, we've got the Office of Pharmacy Affairs, or the OPA. They have oversight of the program. Manufacturers are stakeholders, of course, because they're the ones that have to give us the discounts to the 340B eligible entities, and then we've got the covered entities themselves, the patients, and then what's called the 340B Prime Vendor Program. This is actually a model that pools purchase volumes for 340B entities, and they help them negotiate discounts with the manufacturers. So other stakeholders, in this program and participating in it, you've got your CEO, you have the CFO. Those senior leaders really are responsible for the compliance and integrity of the program. We also have the authorizing official. A lot of times, my experience with our critical access hospitals, that individual is usually the CEO. That is the person filling out the enrollment and the recertification with HRSA. But they are really responsible for making sure that we've got the resources to run this program, because 340B doesn't just run in the background. It is active. There should be active monitoring and auditing going along. It's a complicated program. And then really, if the more collaboration you have with your departments, between your departments, the better your program will be running. So, perhaps a multidisciplinary committee with, pharmacy represented, compliance, credentialing, IT, and finance. Those would be some pretty important roles to have on a committee like that. Trying to move my slide. Okay. So HRSA focus areas, they're pretty transparent in the areas that they focus on. They are looking at eligibility, diversion, GPO exclusion, duplicate discounts, and contract pharmacy. They actively audit these areas. We're going to look briefly at what each of these are, except for GPO, because that is not applicable to critical access hospitals. But hopefully you'll get an understanding of what the risks are associated with these areas. HRSA has indicated that they will audit every 340B entity. So it's important that everyone is ready and prepared for those audits. So the first step to participating in a 340B program is for the entity itself to be eligible. It doesn't take much for critical access. You have to be a nonprofit, and you need to have a contract with the government. They can lose eligibility if your contract with the state has been terminated, if they become a nonprofit, or they fail to recertify during a recertification period. And we have had that happen on a couple of occasions. The second step is, once you identify whether you are eligible to be a participating covered entity, then you need to enroll. And so this is done with the Office of Pharmacy Affairs. There are quarterly registration periods that are open for entities to enroll. And then the authorizing official, again, is the one who completes that enrollment. They become the mayor, the OPA, and HRSA. And then recertification is required on an annual basis. Really very, very important to this piece of the recertification is verifying the outpatient departments that are eligible to participate in 340B. So when I talked earlier about having a collaboration between finance and pharmacy, that is really a crucial point here at recertification to have that going on, to have the finance person helping identify whether an outpatient department on the cost report is eligible. So patient definition, this goes to eligibility. HRSA is pretty clear right now about what type of a patient meets the eligibility piece. They have to have an established relationship with the hospital. So that means that the hospital actually has to have that patient's health record at their facility. The individual has to receive services from a provider who is employed or contracted with a covered entity. They are not eligible if they are only receiving prescription drugs. So this is called diversion. If you're providing 340B drugs to a patient that doesn't meet this criteria, that is called a diversion. Then other types of diversion is the medication eligibility. Again, this is the 340B drug or 340B drug program is for outpatient services only. It does not include the inpatient setting. Providers have to be eligible. They either are employed or contracted. One of the things that I did read in some guidance is that with respect to the medical staff appointments, there was a recommendation that management consider defining what those appointments look like that would make that provider eligible to write these prescriptions for 340B drugs, and then putting that in the medical staff bylaws. I personally have not seen that happen at any of the facilities that I work with in the Fargo division, but not necessarily a bad idea. And then the final point on here, Medicaid, if we are providing 340B drugs to a patient that is already receiving Medicaid drugs at a discount, that is called a duplicate discount. So in essence, that manufacturer is providing a double discount on the same drug. So CHI a few years ago, we had a legal opinion from one of our attorneys that recommended that the 340B facilities carve out Medicaid, meaning that we do not, across the board, we just do not provide 340B drugs to Medicaid patients. I think a lot, if not the majority of our facilities do carve out Medicaid. If they have chosen to carve in Medicaid, they do have to manage that. There's reporting that has to go on. So, we go back again to the resource issue and being able to do that appropriately. And then contract pharmacy, this is the probably highest risk. This is arrangements that the hospitals have with local retail pharmacies to provide 340B drugs to the patients. It's interesting that half of all of the diversion findings that HRSA has in the audits they've conducted relate to contract pharmacy, but it's extremely difficult to manage. And ultimately, the hospital is the one that has the responsibility to ensure compliance. So, they should be requesting quarterly statements from the contract pharmacy, making sure that the drugs are only going to eligible patients. They should be doing inventory reconciliations. So it is a lot of work, but a lot of our hospitals do have contract pharmacy arrangements. From a compliance perspective, with all the focus areas identified by HRSA, this is really what the covered entity should be doing. They should be auditing and monitoring on some level, whether it's monthly, quarterly, annually. I think it depends on the volume of drugs they have in their 340B program. But they should be looking at eligibility and duplicate discounts and the contract pharmacy and policies and procedures. We have gotten, in our HRSA audits here in our division, I think policies and procedures have come up, or the lack of thereof has come up on all of them. So they've had to scramble to put those into place for a corrective action plan. And then I just wanted to share this with you. Back to the growth of the 340B program over the years. You can see the number of audits that they did in FY12 compared to FY15. It's grown pretty significantly. And again, I think HRSA has made it clear that they do plan on auditing every 340B covered entity. So finally, with respect to governing board responsibilities in the 340B program, ask management, ask them about their resources. What kind of auditing are they doing? Do they have resources to do auditing? How is education being provided to all of the individuals that touch 340B? Is there any collaboration between departments? Do you have an oversight committee for 340B? Have the leaders been educated, your CEO and CFO? And then, you know, if there's been HRSA audits, have you been, you know, seeing what those findings are? And then what kind of remedial actions are taken to make sure that the program is compliant. It's a complicated program, but again, provides a lot of benefit to our patients and serving our communities. So I did have, I think I'm missing a slide here, Michelle, but I just wanted to finish up with a couple of final thoughts for our board members. You know, our rural and our critical access hospitals, we know that we face different compliance issues than our PPS counterparts. I thought it was interesting, we used the OIG guidance for our new board members, and as I was reviewing that again this past spring, they referenced in there that the federal sentencing guidelines even say, you know, boards of smaller organizations may need to become more involved in the organization's compliance and ethics efforts than your larger counterparts. And the reason for that goes back again to resources. So I'm always hoping that our board members, you know, are encouraging compliance, accountability with the management and leadership at our hospitals. And then again, you know, I think you heard in all of our takeaways from each of these areas, please ask questions of management. You know, you can always ask questions about what kind of education is being provided to staff on rules and processes that need to be implemented, what kind of auditing is done, you know, enforcement, and then, you know, do you have the resources that you need to work in a compliant manner? So with that, thank you very much for your time today. I appreciate it.
Okay, thanks, Sherry and Randy. And we don't have any questions in the queue, but I did just want to close and reiterate that one of the reasons why we're offering these educational webinars is we're hoping this will help our Audit and Compliance Committee members and board members to understand some of the compliance risks and you know, just the difficulties that are out there with the various programs that we're offering. And this one, we really wanted to focus on the critical access hospital arena because, you know, you don't see a whole lot in the news around the critical access hospitals, but there are a lot of intricacies and things that we're paying attention to. And with CHI's shift to a consolidated compliance program across CHI, it has really enabled us to focus compliance resources and expertise in the areas of greatest risk. And I really appreciate having Randy and Sherry, who are very much focused on those issues that are specific to critical access. And I think it's really helped us to strengthen just our overall compliance in the arena of critical access hospitals. So I do encourage you to take back your learnings. We are going to have this webcast available electronically, and information will come out regarding how to access the webcast. And we encourage you to encourage others that are on your committees and boards to, attend this webcast if they have critical access hospitals in their portfolio. And if you ever have any questions or anything, please know that the corporate responsibility officers in your regions are fully accessible and there to help you with your fiduciary oversight over some of these more difficult areas. So with that, having no questions, we'll go ahead and close, and I thank you all for your participation today, and we will have another webcast in about 3 months. So we look forward to continuing to provide this valuable education to you. Thanks so much. Bye.